Thank you very much for coming back, and I hope you visited all the booths, or at least a couple booths each time we take a break to find out what industry is brought here today, because we work very hard to get them to support the meeting. I'm going to talk to you very briefly about the history of this patient that's in the live case. The live case is relatively short. If there are any questions about technique or anything, please save it for the question and answers. This is a patient that I treated that has post-thrombotic iliac compression. And you can see that she has quite a significant history. She was 48 years old when I first met her. She had postpartum phlegmasia early in her life. She was hospitalized at that time for 2 months because they really didn't treat it anything more than heparin at that time. She never got lytic therapy in 1979. Her second DVT was in 82, her third in 93. Then she presented in 2007 when shortly after that, I met her with her fourth DVT. So she was quite disabled on the left side. She had chronic ache and heaviness, visible transperineal varicosities or collaterals across her perineum. She was wearing stockings. She took Coumadin faithfully. She was really didn't have any skin changes because of her compliance with the stockings, but she did have a chronic venous severity score of 8. So here she is with a post-thrombotic syndrome. She worked at Wells Fargo Bank. She still does. So she toughed it out. She's very stoic, but she was very symptomatic. So I knew that she had an underlying iliac compression, and this is the first case that we're showing of a post-thrombotic chronic iliac DVT that we're going to then treat with endovascular treatment. Thanks. It's great to be with you today. We're going to show you a case of a May-Thurner iliac compression, which is actually clinically somewhat subtle in certain ways. And what we've done is we've investigated this patient with diagnostic venography and with IVUS. And it somewhat shows how the venogram isn't too impressive, but the IVUS is. So what we like to do is introduce this patient. She's a 64-year-old woman who came to me for some additional sclerotherapy, but when she said that her sclero had turned into a medial malleal ulcer before, I thought there's got to be something else going on in this left leg. And her history shows that she had a DVT 30 years ago following a hysterectomy. And then probably about 1 year ago, she had an episode of cellulitis and went undiagnosed with some tibial DVT. So her prodrome is also that she has a heavy left leg, she fatigues, it gets tight, and it's larger by 3 centimeters in the thigh and 1 centimeter in the calf and ankle. So all that being put together sounds like a story for a May-Thurner compression that's never been diagnosed and been giving this lady venous hypertension for years with a couple of episodes of DVT. So we brought her in here today for an evaluation, and we'd like to show you the first venogram. The first venogram shows that the femoral vein looks good, but on the ultrasound itself, there was some non-phasic flow in the external iliac. So that suggests there's a proximal obstruction. And on the digital subtraction of the iliac, you can see that it looks darn good. There is an area that's somewhat low density near the common iliac, but the telltale sign is that there is stasis of contrast in the external iliac area and a little bit of a filling defect, which we can see then again on IVUS.
So now we're doing the IVUS, and you can see it gets very narrow in the common iliac. So it's about 2.5 millimeter minimum diameter, but it measures about 14 to 15 on the longitudinal axis. So this is a good patient that has a definite compression greater than 50%. And of course she's supine now, so when she's upright, it could be even more of a compression and evidence for mid-Thurner. She doesn't have very many collaterals, but we could force the collaterals if we did with a Valsalva, but she's comfortably asleep thanks to Kevin Olina. So what we've done now is we've put a AMPATS wire up, and we've measured with both a balloon, a 16-bore balloon, as well as our IVUS. And we've been able to determine that this is a good stent size, a 1690, which will extend far enough down into the external iliac. So we're positioned now with a road map, and I put the IVUS probe up into the cava to where we want to advance the stent. And we're about ready here now to deploy the stent, and then we'll look again with IVUS. So we have it all ready to deploy. Are we live, Casey? Now I would like you to go off road map at this point. Okay, now watch this. We have some needles in place as well. This is a 16 stent, so as it opens, we'll see it flare. And we want it just up into the cave a little bit, not too far. I'll pull it back down where we're just by the bifurcation, and we'll extend it down into the external iliac, and I'll hopefully have good apposition with all the walls. And so now it's deployed. Good, and now we can do a follow-up venogram. And if you give me full strength contrast, I'll inject here. Good. I'll inject through the sheath, and we'll watch it come up through there. And this time we shouldn't have any evidence of stasis. Okay, live. It goes, coming. Flows going quickly through as it comes through, and it clears. So that looks like a good result. We'll go back with IVUS and then be able to show you those images when we complete them. And the position is good because it's right at the bifurcation, not too high, but obviously we've accomplished the common iliac area nicely. You can see the flow coming in from the right side where it washes out. So this is a good position for the stent. Let's go up with the 16 balloon. We'll dilate our stent just to make sure it's completely opened against the wall. Can you give me an empty syringe, please? Need those balloon wings really far down so you go up into the stent with it open. It's nice to use a new balloon when you're dilating a stent. Okay, get the air out. Okay, there you go. Cool. Okay. We'll go live, please. I'm going to go right to that common iliac lesion. Carefully into that area that's tightest right there. Okay, go ahead and inflate the balloon, please. It'll foreshorten slightly when we do this, but we have margin for that. Go up to 4. Good, okay. Okay, now come down slightly. Just go ahead and deflate. You always want to extend that wall stent up just a little bit beyond where you want it to position, so when you dilate and it foreshortens slightly, you have that margin. And we'll come down here and go up one more time. See how I'm staying above the wall stent because chance of harming the balloon. Yeah, just a little bit. Okay, that's enough. Come down. All right, and then we'll go back with IVUS. Okay, we'll take that out. Take this off. Makes it easier. Okay, balloon is going to come out. And we'll do an exchange for our IVUS.
On the top of the wall stent, you can catch a non-compliant balloon. If you're not careful, it
So
can
in this
pop the
patient's
balloon.
case,
So you have to be
her
careful about
symptoms
that.
are really related to a proximal obstruction, plus the accruance of some DVT that is residual in the tibial vein, so that affects her calf muscle pump. So we'll see how much relief she gets from opening up the proximal narrowing and high pressure. She does not have any reflux in her saphenous vein. She does, however, have reflux in her distal femoral and at the popliteal. And interestingly enough, she does not have deep reflux on the right side. So that's another clue that she had a left proximal obstruction. And I think clinically we're missing a lot of these because we don't connect the dots with the signs and symptoms. She's a mixed bag because she does have some reflux from long-standing venous hypertension proximally. But when we relieve this obstruction, she'll get a lot of relief. And then we can reevaluate her valves with a standing position. At least it might mitigate against further damage to the valves. Now, she's a good example of a patient in whom saphenous ablation, or in her case, foam injection of some varicosities wasn't a good idea because she had a significant amount of venous hypertension coming from a proximal stenosis. And those are the kind of people that actually get worse if you do the superficial system without correcting the underlying lesion. Okay, this would be the IVUS. We use the 6 French eagle eye for these veins, even though the veins are somewhat larger than coronaries, obviously, but we prefer the imaging that I get here with this. And this is an 014 system. There is an 018 system available. We'll go up here with this monorail, 6 French. Now, left over from her episode 30 years ago are some synechii in the external iliac vein segment. Do you want to ring down, please? There you go. So we see those. This is the normal femoral vein in her thigh coming up. And once we get to the common femoral external iliac, you see some webbing, which is actually residual unresolved old thrombus. Right there, see that? There's like a web effect in the vein from an old, unresolved, or completely resolved thrombus. And this is external iliac there. See another area where there's a little bit of webbing or synechii, but not obstructing flow, to my estimation. And then we see the stent in place, which is well opposed to the vein. The vein is actually slightly larger there in one diameter. And here we are coming up live into the common iliac segment. You can see the stent is well opened, and there's the IVC. Now, if you would put on the chrome, please. Chrome flow. And we'll show you with the color flow. Record. Okay. And we'll pull back from the IVC, and you will see that the stent is not too far in the IVC. There's good flow from the right side. And there's the thickening, the high-density echogenic material from the old May-Thurner compression. And the stent is open with good flow through that. There's a bit of an area where the vessel is actually wider in one dimension than it is the stent, but the flow will go through there. There won't be any problem with any thrombosis or anything, and the hypogastric will empty nicely into there. And there we're back into the normal vein. And those little web effects down there distally. Okay, thank you. Well, I think that's a good result. It'll really help her clinically, but of course we won't know until we take the sheath out and she's able to walk and tell us for certain. But I'm pretty sure this will help her a lot. Thank you very much.
Oops, sorry, excuse me. Well, I'm sorry we had the wrong introduction. The introduction for the next case was there, but this lady did, in fact, undergo some flow-directed thrombolysis of her left leg by a pedal IV and the tourniquets that we use to direct flow into the tibial system. So we opened up her tibials and her perineal trunk area quite nicely. And the whole combination allowed her to heal that ulcer. She's done very well. She just had her 1-year follow-up, and she's doing well clinically. So it did make a big difference to her. Actually, she's one of these people like Dr. Rook was talking about too. Now, since her venous system has improved, she walked a lot more. And now she's got arthritic knee, and they want to know if they can do knee surgery on her. So these people come to you with a bundle of ailments by the mid-60s. So venous is just one part of it. All right. Let me get my program here. So we're going to move on with the next case, and then hopefully we'll get the introduction straightened out for the live cases. The first talk is going to be by Dr. Bjornson. Haralder's a good friend of mine. We were together at the University of Minnesota, and he is now Chief of Interventional Radiology at the Mayo Clinic in Rochester. He's going to start the deep venous session talking about May-Thurner stenting and understanding which patients to select and when to treat. Thank you. Welcome.
Thank you, Patricia. I will be spending hopefully no more than 12 minutes talking about the venous compression syndrome, and I will try to focus on when to treat. I have no disclosures. But first, before I go any further, I would like to emphasize the complexity of the venous hemodynamics and how very little we actually understand when it comes to it. We are used to dealing with the hemodynamics of the arterial system, which are quite straightforward. We know that a 50% diameter stenosis causes a critical stenosis or hemodynamically significant stenosis. But when it comes to the venous system, we don't really understand. When is a narrowing significant? And do we have any sensitive tests to determine when to intervene and when not to intervene? This is a new paper by Dr. Raju, just published in the last issue of the Journal of Vascular Surgery, the venous and lymphatic portion of the publication. Demonstrates a test on the table, a bench test, which has been known for a long time by the cardiothoracic surgeons, which in practicality is a rigid tube with a Penrose drain inside. By applying pressure on that rigid tube, you can actually imitate the intra-abdominal pressure. And you can also imitate an outflow stenosis here, and then at the same time calculate the pressure in the inflow vessel. And if this would be an iliac vein, this would represent the outflow stenosis in the common iliac vein. This would, not in the right order though, reflect the intra-abdominal pressure, and then they can measure the pressure here. This is what they call the Starling pressure. which is the intra-abdominal pressure. This is 5 millimeters, 10 millimeters, 0 millimeter, 5 millimeters, 10 millimeters, and 15 millimeters of intra-abdominal pressure. And then they applied a gradual increase in outflow stenosis, iliac vein stenosis, we can call it. And you can see that any increase in degree of stenosis on the outflow, the common iliac vein, with a very low intra-abdominal pressure causes significant inflow pressure rise, which would be the femoral vein rise. But as you increase the intra-abdominal pressure, the effect of the stenosis in the iliac vein is supersized, or the intra-abdominal pressure will override any degree of stenosis in the iliac venous system. This goes to show how important intra-abdominal pressure is, thereby adiposity, and how little we really understand about the function of the iliac vein stenosis in this case, and the interplay between abdominal pressure and fixed stenosis. Now I'll talk about 4 different entities briefly as far as the venous compression syndromes, the thoracic outlet syndrome, which you all are probably very well familiar with, caused by compression between the clavicle, the first rib, the anterior scalenus muscle, and multiple ligaments and smaller muscles. The first rib can also be a causative factor, so we have to be aware of that when we do the diagnosis. Venogram is probably still the test of choice. We do it with a neutral position, and then with the arm at 90 degrees, and then stretched above the head. And here you can see a nice depiction of the obstruction of the subclavian vein centrally, usually at the medial aspect of the first rib. You can also note that there is an impression where the pectoral muscle connects to the coracoid process. Uncomplicated thoracic outlet syndrome on the venous side is a surgical treatment. It is usually accomplished by removing the first rib or the cervical rib, if there is one, and usually a venous patch. Occasionally we are still asked to intervene after removal of the first rib with angioplasty, and we can actually place stents also at that point, but before removal of the first rib, stent placement is not advocated. Now, thoracic outlet syndrome is associated with higher incidence of the thrombosis, and we have different names for that entity. Thrombolytic therapy is our entry point into the management of this syndrome there, and then surgery is usually performed as described above, either immediately after successful thrombolysis, or some surgeons prefer to wait 6 to 8 weeks and leave the patient on anticoagulation. This is just an example of a successful thrombolysis. Nutcracker syndrome, another relatively rare entity. We talk about anterior nutcracker syndrome, by far more common, caused by the left renal vein passing under the supramesenteric artery and being compressed between the aorta and the supramesenteric artery. There is a more or rare or less common entity, that is when the renal vein passes behind the aorta and is compressed between the aorta and the vertebra. Treatment diagnosis is usually by either CT or MRI. Those are both very nice diagnostic tools. Ultrasound in our hands has also become a very important part of the diagnosis, but I think direct venography is still the key. There are criteria for ultrasound diagnosis based on peak systolic velocity, but also on the diameter at the hilum and across the area between the supramesenteric artery and the aorta. Direct venography allows you to get a good sense for the hemodynamics. You can measure pressure, and we use 2 millimeters of mercury as the cutoff point. This is a depiction of a venogram. You can see the impression by the superior mesenteric artery. Measure gradient, which was 4 millimeters in this case. You see the retrograde flow in the ovarian or the spermatic vein, and then cross pelvic flow like this. Management, it is a very difficult clinical evaluation and a very complex symptomatology, so we try conservative treatment in the beginning. Traditionally, surgical intervention is the gold standard, which consists of transecting the vein where it enters the inferior vena cava and bring it down the caudal away from the origin of the superior mesenteric artery, and often a patch is needed. Endovascular treatment has engaged the popularity over the last years. It's a fairly simple procedure, but we have had difficulties as we do not quite understand the physiology caused by the compression by the superior mesenteric artery, and there have been reports of stents migrating to this inferior vena cava. What about the outcomes? This is a study from the Mayo Clinic which looked at patients that were treated surgically and, on the other hand, conservatively demonstrated that the surgical patients did better, but again, this is a cohort study, not randomized. This is a Chinese study, looked at 61 patients with nutcracker anatomy treated with stents, and all of them did very well. So stent placement seems to be paving the road into this arena. Iliac vein compression, I do not have to introduce this entity, as we all know about this. It is traditionally thought to be caused by compression of the common iliac vein by the common iliac artery on the right side, as depicted on this image here. But there are also some speculations that it may be embryological in origin, as this image here may depict. With other words, it doesn't look like only a compression, but more of a irregular development of the migration in embryo of the venous segments. But enough about that. This is a compression clearly. You can see the retrograde flow into the iliac vein. You can see a CT scan here, which I really like. And there are papers that indicate or have proposed using 4 millimeters as a diameter of the lowest point as an indicator of significance. Now, this is not combined with any hemodynamic studies, so shouldn't be used as such. Venogram, intravascular ultrasound, which we use not always, but can be very helpful in cases where there is, well, this is not running, but we let it go. In this case, we decided, based on a 1 millimeter pressure gradient, which we would not consider significant, but because of the look on the IVUS study and on the venogram, and giving the clinical history to stent this, and this patient demonstrated improvement. This is one of the papers from Raju and Naglan demonstrating use of stents in patients with leg swelling. Portion of these patients had no reflux, and another part of the group had reflux. They decided to treat all of these patients with stents, but not address the reflux at that time. Demonstrated that there was a significant improvement in the patient's symptoms, both the reflux group and the non-reflux group. With other words, those are patients that had not had a thrombosis previously and were treated with stents and had very good symptomatic improvement. They also pointed out that there was not only the traditional compression by the right common iliac artery at the central left common iliac vein, but there were other pressure points that could be important also in the iliac veins, causing a fixed stenosis. And those are mainly at the takeoff of the internal iliac veins bilaterally, and also where the right iliac artery crosses along the right iliac vein. And this is just a picture from their paper. So when you are evaluating patients with the thought that they may have May-Thurner syndrome, the history is very important, and you have to think of all the causes, obviously, as mentioned in earlier talks. Venography, both conventional and CT and MRI are very important as start-off points. We use pressure measurements, but we understand the limitations of those. We use a gradient of 2 millimeters as a cutoff. I think intravascular ultrasound is very helpful. We do not understand very well how we can use it. There are no standards or guidelines as far as what is significant. This is a paper that we presented, published recently. This is a patient with retroperitoneal fibrosis, which I had stented his IVC for. He then presented with shortness of breath and was not feeling well, did undergo a right heart catheterization from a jugular vein approach. They have the patient's bike on the table, so they are lying flat but have a bicycle. They placed the catheter distal to the obstruction that you can see on the right side here, actually on your left side, and found that the upper one is the pressure gauge before they started having the patient bike, and then now with the pressure gauge below the stenosis and the patient biking, and then they pull the catheter back, and you can see by increasing the blood flow you can increase the pressure measurements, and we are guessing that this may help us engaging what is a hemodynamically significant stenosis and what is not, and we are planning on doing a evaluation of that. Finally, something that I had not actually thought about is a popliteal vein compression syndrome, very common entity. Again, Raju and Neglen wrote this up in 2003, I believe. They had 30 patients, treated them like popliteal artery entrapment syndrome. Those were the symptoms they had, and I want to point your attention to the ulcer prevalence, 30%. And they got significant improvement in most of these patients by releasing the popliteal vein band. Finally, compression syndromes are frequent, and I have many anatomic locations. They are either anatomic variants, or those are also acquired as we get older. The aorta, the iliac veins become elongated, ectatic, and the position as far as the venous system changes. We do not understand the hemodynamics easily, and we have no standard imaging really, except for maybe the nutcracker syndrome. I would advocate cautious endovascular treatment with good attention to the history and the medical findings, imaging findings. Thank you.
Thank you very much, Haraldur. I appreciate that complete review. So next, I'm going to give a talk about IVUS and some images from the variants of May-Thurner. There is a variability in how much people use IVUS in the country with regard to imaging iliac compression syndromes. We recently saw one for a nutcracker that was very tight. And we always are reminded in our training that we treat the patient, not the x-ray. So sometimes we see things, and then we have to decide whether or not it's a critical stenosis, like Dr. Bjornsson was saying. These are my disclosures. So the iliac compression syndrome is present in estimated at least 20 to 30% of the population. That's a very large number of people. We think that people are pre-selected for iliac compression when they present with a left leg DVT, and most DVTs do occur on the left side more than on the right side. So they can be asymptomatic, symptomatic with no DVT, symptomatic with an acute DVT, or symptomatic with an acute DVT superimposed on something chronic, or just a plain chronic disability from an iliac compression. And unfortunately, in the world of non-invasive vascular imaging and duplex, a lot of people who present with a DVT get evaluated from the inguinal ligament to the knee. And they do not get the order put in for IVC iliac imaging with ultrasound, which I think is kind of an omission in a lot of places. And when we do the IVC iliacs, we find a lot of signs of the May-Thurner compression or obstruction. Now, this is a patient with non-thrombotic May-Thurner syndrome. She's a functional attorney, but she has swelling in her left leg for many years, and you can see the difference, and it bothers her, but you have to rate their quality of life to see whether or not she would undergo a stent procedure. I think 20 years ago, we weren't stenting people as much as we are now for this type of non-thrombotic syndrome, iliac syndrome. Here's a left lower extremity DVT. Looks very similar to the last patient, but she's already had her DVT, and she has a post-thrombotic syndrome. Here's a 70-year-old woman with an acute DVT 2 weeks post an EP procedure where they put 11 French sheath on both sides. She had a complication on the left and ended up with a massive DVT. Here's a 28-year-old woman who had DVT after taking birth control pills. She's factor V positive. She's had DVT for only 2 weeks, but her whole left leg is involved. Here's another patient who has malignancy as a risk factor for her DVT, which was pretty acute. Here's a 21-year-old woman. The chronic 3-year history of DVT was associated with taking birth control pills and some trauma when she fell on the ice. And she is factor V positive as well. Here's a 13-year-old boy who has never had DVT, but he had an iliac compression. It was picked up on ultrasound, it was seen on MRI, and then it was stented, but his swelling never went away. And we think in his past history he had a significant cellulitis that might have given him some lymphangitis, which translated to a positive lymph channels now in this left leg. So he has a combination of conditions. Now here's some images of May-Thurner. Multiple channels here. Sometimes it's multiple channels, sometimes it's 2, sometimes it's a total occlusion. I think we could stratify it all. You can see here the crossing over of the artery, classic May-Thurner with some collaterals here, transpelvic. This is how narrow it gets on the IVUS. So it's very easy to see that you have a significant lesion with IVUS. And the interesting thing is that to the uninitiated, looking at a venogram where the flow goes through and you don't have very many collaterals, you might say that that's not really a significant lesion, even though the patient is symptomatic. And what we've come to learn is that when we have IVUS, we can pick up on hemodynamically significant lesions in patients who haven't developed ulcers. Now, interestingly enough, this is the patient who had an ulcer because there was a May-Thurner condition, and she presented with this ulcer, and no one had ever picked up on the fact that she had an iliac compression. Now, grant you, this doesn't look very bad here. The flow's going through. There's a little bit of reflux, transsacral pelvic area, but her imaging showed that on IVUS, using the 8 French device, it's quite narrow, 5 millimeters, and you can do the millimeter squared diminishment from the normal vessel, and you can see that's very significant. And here's with a stent. Now, I'm going to tell you of a couple different variations of May-Thurner that I've seen in the past couple of years, and I've given them different names. One of which I call Mega May-Thurner. For many years, years, all we had were 12 millimeter stents, then 14, then 16. Now we can go up to 24 millimeters in a wall stent. And you could put two stents side by side if you had to, but up until recently, I'd never used any of the very large stents. And this patient presented with signs and symptoms of May-Thurner and a history of tibial DVT. You can see that she has non-phasic flow distal to the common iliac. And this is her imaging. She went to several places in California. She's from Northern California, and the imaging studies and the venogram all show that she had this very wide common iliac. In fact, it measured 33 millimeters. So everyone was very reluctant to do anything for her, and they came to me at a meeting once. I said, we have this young girl who has this huge iliac vein. Is it possible to stent her? And we said, well, the maximum size that we know is 24 millimeter stent. But I said, has she ever had IVUS? Because if she's never had IVUS, we don't know how wide it is from the anterior-posterior dimension. And that's the key to stenting, is that you want it to stabilize and anchor at the very tight spot where it's been obstructed for many years. So when you do the IVUS, you can see all this fibrotic tissue, and the narrow AP diameter, even though it's very wide side to side, is very tight front to back. And that will allow you to anchor a stent in here without fear of migration when you put it in the IVC and anchor it down into the external iliac. So we did, in fact, choose a 24 millimeter stent in her and deployed it after these diagnostic IVUS images with the 8 French, and she had one of the fastest recoveries from a May-Thurner, symptomatic May-Thurner, that I've ever seen. It was within 48 hours, her leg was feeling good to her, and her swelling was diminishing. So that was a very successful treatment in a woman who had gone to about 4 different places and been told it wasn't possible for her to have anything done. So, and IVUS, I think, was key to her clinical success. This is what I call a right angle or 90-degree May-Thurner. It's kind of interesting because if the stent goes right across to the other wall of the cava, the flow will go through clearly, but it does somewhat jeopardize the right side. So in this case, when we see the way the stent was going to deploy this way, we took an extension of the stent upwards and also stented the right side. And it's important, I think, in these types of cases to look at both sides with the IVUS. And in fact, this lady has either duplication or a sciatic vein extension, but this was stenotic here compared to this because she had this double anatomy here. There are, in the literature, it says about 2% of people have a bilateral May-Thurner. I think we see it more often than that, but this is a case in which there is indeed flattening of both sides from the aortic bifurcation of the vein crossing over. So both sides of that need to be stented. We saw some pictures from Dr. Bjornson of what I call a double May-Thurner, but it's a double vessel. It's almost like you have 2 iliac veins on one side. These are the images from the IVUS in this patient. Very narrow in each channel. So each channel is symptomatic, and this is after some lytic therapy. You can see that's quite wide, but very narrow front to back. You can see the narrowing here. And there are actually 2 iliac veins. The question is, do you stent both of them or just one of them? And I've seen this several times now, and I think that for the most part you can stent one channel. The other channel will stay as is. And I always stent the external channel here, but it's important to stent all the way up into the cava. And in this patient, we stented a little bit too low, and I thought it was good. It was a young boy who's 19, but he did come back for an additional stent, and that made the flow much better. So when you have competitive flow from the other side or a different channel, it's important to make sure the stent goes all the way up into the IVC. Now this is a second case of a duplicated vein at this level with only one stent and a good result. Recurrent May Thurner, I've only seen this once. I had a patient come back for 16-year follow-up, and she had developed some varicosities, so she came in for an evaluation for a saphenous ablation, and we did the ultrasound and found that she actually had what seemed like a May Thurner, which we had treated 16 years ago. But it turned out that she's had 2 children since then, and perhaps the stent expanded, went down below. You can see the crossing of the artery. So we extended it up with an additional stent and cured that problem. And now she can be treated for her varicosity and reflux. This is what I call the half May Thurner. It's a patient, we've seen this more than once. You see that it's only half of the vein seems to be compressed and the other half seems to be rather wide open. But we don't know what happens to these patients when they stand up. And hemodynamically, it may be more serious when they stand up. And she's had 2 episodes of DVT in the past. And although I was reluctant to stent her at first, when we finally did place a stent, her symptoms completely subsided, and she has had no further episodes of deep vein thrombosis. So iliac compression is pretty important in our whole world. We're all bipedal. It doesn't have cultural boundaries. If you assume that 30% of the patients or the people in the population have a serious iliac compression, then if there are 1 million DVTs per year, at minimum there are 300,000 people with an iliac compression that are symptomatic in that DVT group, and it's probably far higher than that. So it's an issue that is very underdiagnosed and it's very underimaged, and I suspect very undertreated in our society. Thank you very much. Now, next, it gives me pleasure to bring Dr. Rook back to the podium, and he's going to talk about some novel thoughts concerning compression of the superficial vein or hypertension in the lower extremity associated with saphenous vein.
Well, that was close. Kids, you're going to cut me some slack on this one, because at 4 o'clock yesterday afternoon, I was informed that one of our speakers was sick and wouldn't be here, and could I please create a talk that had to do with venous compression, and wouldn't overlap with anything anybody else did. No problem. Well, I'm going to give you some novel thoughts about this. And maybe the conclusion you're going to come to at the end of this is that what I'm offering you is just further proof that Rook is completely crazy here. Since we're going to talk about deep vein compression, let me start, of course, with the saphenous vein. You know, why do we get rid of I'm going to call it a bad saphenous vein, a varicose or incompetent saphenous vein? We get rid of it because, you know, it may contribute to symptoms like swelling, or it may give you pain or stasis changes or even ulceration. Symptoms is a good reason. We get rid of saphenous veins and other superficial veins because of cosmetic reasons. Usually it's not the saphenous we get rid of, it's usually the branch vessels, but every once in a while the saphenous itself will show through, and you can find lots of examples where we have cosmetic problems with the saphenous vein itself. Why else would we get rid of a saphenous vein? Well, we might get rid of it to cut down on recurrences. Here's a good example of a varicose vein. We do something to get rid of it, and gosh, a year later, things look beautiful. But then you come back 3 years later, and you've got all kinds of recurrent varicose veins. And it turns out that these veins, these recurrences can frequently be decreased by getting rid of the saphenous vein. This was a subject of hot debate 12, 15 years ago, when the first 5-year trials started to come in showing that people had less recurrences if you got rid of their saphenous vein. In this case, you know, you could cut down on recurrences by 2/3 if you routinely got rid of saphenous veins that were incompetent when you fix varicose veins. You'd think that, you know, this issue of whether getting rid of veins reduces reoccurrence would be solved by now, but look at this. As late as 2011, we were still arguing about the same thing. and finding the same kind of results, that you have a lot less recurrences in patients who undergo vein stripping or vein ablation. So, what do we do with our asymptomatic, superficial, incompetent veins? Well, you know, we can get rid of them. But remember, if we do, it's going to cost us something. It has the potential to produce some morbidity, and we may lose style points if we tell people that getting rid of their saphenous veins is going to cut down on recurrences, because they're still likely to happen. Now, this background, what I've given you is just a couple of minutes of background, because it has always bothered me that we may remove superficial incompetent veins that are asymptomatic, or saphenous veins that are asymptomatic. And I began to wonder several years back whether we're asking the wrong question. Maybe the question shouldn't be whether we get rid of these asymptomatic, incompetent, superficial veins, but whether we should be trying to keep these asymptomatic, incompetent, superficial veins, including the saphenous. Now, I am not the first person to have thought about this. There are the Europeans, led particularly by the French, who've made quite a career, many of them, out of developing operations and procedures to preserve the saphenous vein in cases where people have varicose veins and an incompetent saphenous vein. Now, I'm a little bit puzzled by these. For those of you who've heard of CHIVA and the ASVAL procedures, I frankly don't understand them. I've talked to many of my colleagues about how these operations are performed. I guess it's just further proof, Dean, that there are two secrets to success, and the first of which is, don't give away all your secrets. I'd tell you the second, but you got to refer to number one here, okay? Anyway, regardless of how these operations to preserve the saphenous vein truly work physiologically, the issue is that they work. We can preserve the saphenous vein even when it's incompetent, and cut down on recurrences of other varicose veins. And articles appearing in the literature like this one are not uncommon. This is a pretty well documented phenomenon, that we get much lower reductions in vein recurrence when we do certain operations that still preserve an incompetent saphenous vein. All right, well, why am I worried about this issue of preserving an incompetent saphenous vein, and how does this play in with the question of compression of deep varicose veins, which is the topic of today's session? Why would I worry about this? Well, here's the reason. We all understand the general consensus about how venous flow works under normal, basic physiological circumstances. We've got deep veins that return flow, we've got superficial veins that return flow, and we've got perforator veins. All of these have valves in them. We have perforator veins that allow blood to flow from the superficial into the deep veins. And this is what happens under normal circumstances. Now, if a superficial vein becomes varicose, like we've shown here, blood won't necessarily flow back in the normal fashion. And remember, we're a nation of couch potatoes. We work mostly at very low workloads. So we do a lot of standing in this country. We do a lot of sitting. You're sitting right now. We do this. If you have these incompetent superficial veins, you're likely to wind up with reflux, accumulation of fluid, and edema formation. Now, that's why we tend to get rid of these veins. We get rid of them because they help us at low workloads, at low intensity activities. We do better if we don't have these refluxing superficial veins. But let's think about some other circumstances that we're likely to encounter in real life. What happens if we develop deep venous obstruction? Well, then the venous return pattern can change considerably. We can get blood that flows through the deep veins, encounters the obstruction, and is forced to exit via the perforating veins and basically collateralize, basically return around the obstruction through the superficial veins. You know, this is probably more common of a physiological occurrence than we give credit for, because at least low in the legs, the perforators are very often incompetent, even in normal people, or you'll see bidirectional flow. So this isn't, you know, such a far-fetched idea, and I think it's a pretty commonly accepted idea of what happens with deep venous obstruction. Now, the problem is, usually we think of deep venous obstruction as being a pathological situation caused by something like clotting. But the reality is, as we've learned in this session today, there are physiological things that can compress the veins and cause obstruction. One is a basic pinching phenomenon, and Dr. Bjarnason made mention today of the popliteal entrapment syndrome. There are people out there, more than we probably imagine, who can compress and pinch off the deep veins at the popliteal. You know what else can happen? We can get muscle hypertrophy that can compress and close off our veins. And you say, how would you do that? You know, how would the muscles get so big? Well, we do it all the time when we exercise or get ourselves in shape or actually build muscle. The larger these muscles are, the more tendency they'll have to compress the deeper veins. And if you add a combination of muscle build and flexation, you really set up a situation where the deep veins can be obstructed and the superficial veins need to be relied on for collateral flow. Now, I hear you all out there being skeptical. Rook, how often can this happen? I had no slides with me today to prepare this talk, so all I had to do was jump on the internet and grab any one of 10,000 pictures that are on there of bodybuilders. Bodybuilders get all excited when their veins pop out, because in their minds, on these bodybuilding websites, they'll tell you that the reason this happens is because we've got our body fat down to minimal levels. But look at the veins that are popping out. Folks, these are not normal veins. There is absolutely no question that the only reason these veins are existing is because the deep veins are completely occluded by their large flexing limbs here and big muscles, and these are acting as collateral veins that are carrying the blood back. So the whole concept, you know, these people with these bodybuilders make notoriously bad athletes, bad boxers, bad football players and things. They get called muscle bound because they poop out quickly. It's probably because they're having so much difficulty getting their venous return back. Now, under other circumstances, I mentioned obstruction, but there's also the situation of exercise-induced hyperemia. When you exercise a muscle, the blood flow through the arteries goes up, and now the return venous blood flow has to go up, and that often requires additional recruitment of superficial veins. And if you throw in intermittent compression and big muscles that are compressing the deep system, it can be a big issue. And just to illustrate this, again, I jumped on the internet, and I think you recognize this pretty face here. I want you to look at his upper arm here. It's not very impressive in terms of his venous vasculature. But how about a picture of this same man taken an hour later when he's actually using these muscles to maximum capacity and when he's very hyperemic? Look at this. If you were to somehow eliminate that gigantic superficial vein he's got, you'd probably cut down a substantial amount of his returning blood flow. And I'll give you one more example here. Bicycle racers, they become very hyperemic during a race, and they're subject to having large muscles that also become hyperemic and swollen and doing a lot of pinching off of their popliteal space. Is it any wonder that this particular Tour de France winner here, George Hincapie, has left his varicose vein, has developed these kind of veins and has left them? I ask you, audience, are these veins useful? Should he keep them? So I'm going to leave you with a thought here. Some veins, maybe even the incompetent ones, might be good for you. And if you're an athlete and your deep system becomes intermittently compressed, maybe that's the case. See, I told you I was going to leave you with the idea Rook was crazy here. Thank you very much.
Well, good. Worked out okay. Thank you, Tom. It's a hard act to follow, Dr. Rook. Okay, we're going to switch now to some IVUS imaging with regard to restenosis and evaluation of restenosis and stents. The first stents I put in iliac veins is 1993, April of 93, so it's 21 years ago. So I'm very adamant about the responsibility of following patients who have venous stents, because when we started putting them in, no one knew, but we thought it was a better alternative than what they had in front of them as young people or older people with no therapy or major surgery that didn't have too good of a prognosis. And I want to acknowledge the work of Patty Zenda, my RVT, and Dr. Ossie, who works with me down in Sao Paulo on these studies. But for the first 15 so years of venous stenting, I kept track of a lot of the data. And up until the year 2001, as you can see, there was only 681 patients. There were only 681 patients in the literature, which is mostly the North American literature, one Belgian article, and Dr. Sullivan in Ireland, and Dr. Raju in England. But with the interventional radiology represented the other major articles of any series. So 702 limbs, and number of stents per limb averaged about 371, or about 53% of the cases that were treated for DVT were getting a stent. Then the number of stents that had been placed up until 2000 were about 583 that were accounted for in the literature. In the iliac, most of them went 80%, only 14% in the femoral, only 6% in the IVC. So you can see we're doing thrombotic and non-thrombotic iliac stenting early in the first 10 years. And the technical success is very high. It's 95% with primary patency. In my series, about 70%. Overall, about 77%. Assisted patency even higher. People don't usually rethrombose, but they do get restenosis, and that's the topic we're going to address here. The follow-up range at that time was relatively short, but our average follow-up at that time was almost a little over 3 years. But in fact, a lot of patients who get venous stents don't get followed. And if they thrombose, we don't know it. So we have been fortunate that a lot of our patients have followed us. And so we have knowledge about stenting now for up to almost 20 years, since we started doing it in 1993. But when it comes to the incidence of restenosis, it's variable, and it happens at different times in some people, sometimes at 2 years, sometimes we've seen it at 10 years. Now we saw a patient come back with 16 years follow-up, and the restenosis was very mild and wasn't impeding her flow in the femoral stents at all. So I ask you, a la Dr. Rook's kind of questions, what is this stuff? Now it's inside the vein, and you can't very easily get it out. You can see it there lining the circumference. Sometimes it's sort of eccentric, sometimes it's like this other one was completely surrounding, almost circumferential, leaving a lumen here, and it's actually quite a significant reduction of the lumen. With IVUS, you can measure the millimeter squared reduction. And it causes people to be symptomatic. And so what is this stuff? I called it hyperplasia, thinking of the arterial issues, but in fact there's very few biopsies have taken of this, but Dr. Wakefield and Dr. Williams at University of Michigan, in combination with Dr. Camarada, have been studying some of the biopsies that Dr. Williams has been obtaining. And in fact, it isn't hyperplasia a la the arterial system with smooth muscle migration or anything like that. It turns out to be a form of old thrombus. So I'm going to start calling it venoplasia, for lack of a better term, because it doesn't belong there, but it doesn't seem to be coming from the cell wall or the vascular wall. It's probably related to anticoagulation and flow dynamics and a buildup of thrombus and fibrin early on. So I'm going to share with you our data of 85 patients, pretty evenly split, average age of 45. and 97 limbs, most of which were left-sided, as you can see, some bilateral involving the cava. The left iliac was the most commonly stented, 34 patients, or 34 limbs into the IVC. Most often, left femoral, we stented down into left femoral sometimes, and the right side less often. In the follow-up between 3 and 118 months, or an average of 6 years, we saw 4 occlusions. One went to lysis. 3 patients were lost to follow-up. 8 patients died, and that involved 9 limbs, and they died of issues mostly related to malignancy or cardiac disease. And so 82 out of 97 patients, or 85%, were followed up until 2003. And the clinical pattern is this. If you get restenosis, they start developing a little bit of edema and discomfort. They tell you that their leg used to, when it swelled, it used to go down very quickly. Now it takes longer for the edema to go away. The duplex is usually read as patent stents, so that doctor says, you know, your stents are open, and the patients say, yeah, but why does my leg feel bad? Is there something wrong with my leg? Well, the stents are open, there's flow, because they're only looking at whether or not there's flow, not the velocity changes that we have been following. So possibly people have not been anticoagulated all the time if they were hypercoagulable, because a lot of people don't get worked up for that. And a venogram for restenosis usually shows flow as well, just like the duplex. So that doesn't always show stasis. So many patients have come to me, and having had a venogram, they say, well, the stents are open. What's the problem? So IVUS is the key to seeing restenosis. And we can intervene through the right IJ or the popliteal. Right IJ is easier. The patient can go home rather quickly. And it's just an outpatient procedure with a long sheath going down into the iliac side or the stented side. And before we had IVUS, we used to just balloon these patients, and we found empirically that they improved. We couldn't really see the restenosis very dramatically, but we would dilate the stents, and the patient's symptoms would regress, and they would feel much better. Well, once we started getting the IVUS, we could document what we were actually doing. So most of the patients had balloon therapy only. Lytic therapy was involved in some, but you can see that the assisted patency results were quite excellent. And restenosis was seen, in 7 out of 82 patients, or 8.5%. I would say that it ranges between 10 and 15% restenosis in the patients that we've stented. But mind you, I keep most of my patients anticoagulated. So IVUS is superior to single-plane venography in detecting the extent and severity of iliac compression from the get-go. And the 50% guideline is adopted without collateral flow, and that has been put in the literature by Drs. Raju and Neglin. But the transcutaneous duplex is fairly unreliable for detecting not only the original May Thurner, but for seeing any restenosis. And there's a high false negative rate, particularly in looking for reasons why there's recurrence of symptoms. So this is a patient we treated in 1997. He was a young man, 17 years old. They told me he didn't have a cava, but he had an occluded inferior vena cava, and he was born with 1 kidney, so it was probably occurred very early in his life that he occluded his cava. And this is the stent system that we put in 1997 with wall stents. He developed venoplasia or restenosis symptoms in both the IVC and the external iliac on the left side. About 10 years later, he had a sort of a slow prodrome of developing hyperpigmentation and then a small ulcer. So when he came to us in 2007, we discovered that there was that lesion, and we treated it with angioplasty, and we actually extracted as much as we could with an atherectomy device, and we sent pieces of it to the lab. and they showed that it was very unusual. It wasn't exactly intimal hyperplasia, and it wasn't thrombosis. It was more akin to arterial disease than we would think. But the anatomist thought that perhaps that was because he had some kind of a congenital embryological anomaly. So that's kind of just a singular case. Nevertheless, we did send samples, and you can see that you can debulk a little bit, but you can't do too much in these lesions because we don't have the right tools to get rid of this venoplasia unless it's very tight, and you can debulk with this front runner or other devices. So he came back again one more time with symptoms from the caval lesion, and at that point we put in a VisiPro stent, and you can see the dramatic effect of improving and compressing that venoplasia out to the wall, and you can barely see it sandwiched between the two stents. So a balloon expandable stent within a pipe of wall stents with venoplasia is actually a very effective treatment. We've been following these patients now for about 4 or 5 years, and they're doing well. These are stents placed in July of 1998. We just saw them in April 2014. You can see a little bit of intimal hyperplasia here, but actually that was not stenotic at all, enough to cause symptoms in this patient. This is a patient who had multiple stents, multiple revisits, and she ended up having intimal hyperplasia on her right side only. She's prone, so this is her right side. That was her bad side from the very get-go. She had had a heart cath when she was a little girl, damaged her right veins and her cava. And I want to show you that when we measure velocities in the common iliac, external iliac, and common femoral vein, in May of '09, you could see that they were pretty normal. That was after her initial stenting to revision. But she came back about 6 months later, and you can see that the common iliac vein velocity was down to 19 centimeters per second, whereas in the external iliac vein it was up. So it was more stenotic here. And after treatment with angioplasty in February of that year, she pretty much normalized her velocities throughout the entire iliac system. And then she came back about 8 months later, and again she had a decrease in her velocities and an increase in the external. So where the intimal hyperplasia or venoplasia occurred, you can track that with velocities if you have a baseline set of imaging and numbers. So this is the stenting in her. You can see what we did was on the right side. Then after an angioplasty, you can see it looks much better, bigger area. On the left side, and again after angioplasty, you can see that it's much improved. Just balloon angioplasty alone seems to compress that venoplasia thrombosis type stuff. And the results are that you can measure with IVUS the area squared. So you can see that in the beginning, the ideal stent diameter versus what was left in the lumen was about a 45% difference. Then after one angioplasty, it was a 30% some difference. And then after 2 angioplasties, we were down to less than 20% difference, or at least an 80% viable lumen. And that was enough to restore this patient's symptoms. Take away this patient's symptoms of bloating and venous congestion syndrome, because every time she got stenotic with hyperplasia or venoplasia, she would develop outflow through her ovarian veins and get very symptomatic. So once the hyperplasia issue or the venous hypertension in the iliac system was addressed, her legs were normal and she didn't have those other symptoms. So again, I think it's an undertreated condition. We have to be obliged to these patients with venous stents, no matter where they are, to follow them with duplex ultrasound. And if they're symptomatic, take them to the cath lab and do this outpatient procedure to see if we can make it better for them. Thank you very much. It gives me great pleasure now to have the last talk of the session with Dr. Francisco Ossi, who comes to us from Sao Paulo, Brazil, where he has originated and evolved a very good venous center. And he's going to talk about complications in venous procedures, some of which do involve stents. And then after that, we'll have a question and answer period if we have some time left. Thank you. Thank you. Welcome.
Thank you, Dr. Patricia. Thank you, everyone, to be here today to this very important meeting. I was asked to talk about complications, and to tell the truth, complicated was, for me, was to sleep last night after the Brazilian soccer team game against Germany. So I will ask you to forgive my English today. I don't think it will be better than it was before. So to talk about complications, if you go to the literature, you will find a lot of different publications about that, but only a few are really good for us to get, real good information about that. And when we do that, we find two different things. That venous procedures have complications, but they are not very different, too different from what we see in cardiac and arterial and intracranial procedures. So they are safe, and we are very good on doing that. The second thing is that when you go through the numbers, what we find is that major complications are related to technical problems. So they're related to how you do those procedures, how you see your patients, how you treat them. So what is really important? The first thing I would say is that if you decide to do venous procedures with your team in your hospital, don't think arterial, think venous, because if you think arterial, you will have complications, because you must understand the venous disease, the venous anatomy, and the venous physiology that is totally different from the arterial side. And if you think about the normal venous anatomy and what you find when you're treating a patient with DVT, you can imagine where your guide wires and your catheters will go through, and how difficult it is, and how you get in trouble if you don't understand that. Other thing is to avoid judgment errors. What we see in our city, in our country, is that there are a lot of doctors that do mostly arterial procedures that suddenly decide to treat a venous patient, and they think that what they know about the arterial procedures will be more than enough to do that. And this is not true. So if you get rid of thinking arterial and think venous, you will avoid judgment errors. Also, don't wait to take your patient, if you see anything going wrong, back to the angio seat, because the venous physiology tells us that it takes only a few minutes to hours to lose everything you have been doing for days to treat that patient with rethrombosis. So what is important to your venous team is to fully understand the patient's problem. So every patient is different from the other. So if you have to go through all the general protocol to see all the problems that he has, and to decide if this patient is really one patient to take to the angio seat and treat. We do have a 12-page procedure protocol that we go through during the patient treatment, and that we take to the ICU, to the angio suite, to everywhere, to discuss with all the teams, all the specialties, to make sure that we will be in the same page during that patient treatment. Total concentration to the patient procedure. What does it mean? Is that these patients are not 1 day, 1 hour procedures. These are patients that will stay in the hospital for days, and you will take them back to the angio suite 1, 2, 3, 4 times. So you have to be ready to be at the hospital the entire day, and to not hurry to finish your procedure. Total communication. these are patients that you have the involvement of many different specialties, hematology, ICU, everything, general surgery. So these specialties must know what you are doing, and you have to go to them and talk to them to discuss that protocol to avoid complications. If you don't do that, you will see these kind of complications. How to point here? So this is one patient that we had to take back to the angio seat because one doctor, one colleague decided to treat a May-Turner syndrome, and what we see here is that he implanted a stent and is not crossing the artery. So actually, he took the patient to the angio seat to treat May-Turner, and he didn't. The artery is still here, and the stent is away from the problem. The other thing that we see is when they don't think venous and they deploy the stents into the venous system and they don't think about how thin is that vein wall. If you deploy and you don't pay attention to the overlapping of the stents, what you do have is a vein wall rupture and the bleeding into the abdomen. The other thing that we see a lot is that they don't choose the right size of the stent, and what you have to do is to go after that stent into the right atrium and retrieve, and this is what you find and what you get back. Other major problem is that they don't understand the venous physiology, so they just use the material that they have on their shelves, and they don't choose the right stent to use. And what we see here is that the stent design is not in line, and this is cause of rethrombosis because you have the turbulence of the vein flow, the blood flow coming from below, and the turbulent flow here will lead to rethrombose. And people that don't understand the anatomy, they will just deploy a filter into a wrong place that you can see here. They thought they would be in the cava, inferior vena cava, and actually they were in the gonadal vein. So here's one complication that we saw many times. The ICU is a major part of the game, because if you don't discuss with them, your patient will be sitting there for hours that you're not in the hospital, and whatever happens in the ICU will lead to major complications. So what happens there? They have an overload of other kinds of patients, and your venous patient sometimes is a patient that is just sitting there with an infusion of TPA, and actually they are not very difficult patients to treat, so they just leave the patient there and take care of the others. But these patients are the ones that in minutes will just present with major complications, and if they don't understand that, if they don't follow your protocol, that patient will turn into the most complicated patient of the ICU. So they must know the protocol, and what we do is to every 2 months go back to the ICU and take the nurses and the doctors to a room and discuss every page, every step of the protocol to make sure that they understand what we are doing, the kind of patients that we are taking to the ICU, and to be at the same page as we are during the procedure. So this is what we see there. The nurses trying to hide the bleeding of your punctures site, and this is what we see the next day when we get there to see the patient. Or sometimes during the night, they come to withdraw blood samples, and then next morning when you go back to the hospital, this is what you see. So the leg's okay, the procedure is going fine, you just got the way to cross the occlusion, to put a stent, to do the angioplasty, but you have to stop everything just because someone didn't follow the protocol and took blood samples from an arterial puncture. Sometimes the ICU can help you because if they follow your protocol, they will understand and they will find and discover internal abdominal bleeding in a timely fashion, and then you have the chance to help that patient. Or, as I had not too many time ago, an epidural bleeding, and they took I wasn't there, and they took the patient in less than 1 hour to the OR, and the neurosurgical team helped us a lot. So the ICU took the advantage to be there and call the neurosurgical team and help me a lot because they were understanding what we were doing. In the angio suite, I think the most important things are scheduling. So we do not schedule our procedures to the end of the day or at night after you go you come back from your office. It's always in the morning when everybody's awake and everybody's paying attention to what they're doing. Other important thing is the material. You must make sure that your list of material has been seen and you have everything you need to do the venous procedure. The people must understand, and we also sit down with them and discuss this procedural protocol and the other teams that are working with you. And this is why. This is one of our patients that we were doing a procedure, and we were talking about complications, right? And during the procedure, the people from anesthesiology needed a blood sample, and they decided to make a puncture into the jugular vein to withdraw blood. But what they did in this patient that was receiving TPA and heparin was that they punctured the carotid artery. And we were working down here, and this is what we had to deal minutes later. Or if you don't have the right material, so they just bring to you what they have, and you just keep mixing stents and balloons and everything. This is what can happen. So you have a totally thrombosed segment with stents just because you didn't have the right size and the right stent to use in the middle of this reconstruction, and everything was lost just because you didn't have the right material. So to do a venous procedure, it looks like a very easy, and for our friends, our vascular friends that do most arterial procedure, it looks like very easy, uncomplicated, and anyone can do that, but it's not true. If you don't understand what you're doing, if you don't understand the anatomy and the physiology of the venous system, you get in trouble and you will have major complications. Thank you.
Thank you. Well, I think we've sort of run out of the time for questions and answers. Anyone can come up to the speakers and ask us, and I'll try to build in some time in the afternoon. We have an hour for lunch, and then we'll be back here shortly after 1 o'clock to start a very good afternoon session too. Thank everybody for staying and attending and for all your good attention. Thank you.